Welcome. I am Jonathan Rubin, the chair of the Department of Mathematics at the University of Pittsburgh. On behalf of my co-organizers, Cassie Haight and Satish Iyengar, I thank you for joining us for this event, Perspectives on Health in Equity Across Communities, organized as a collaboration between the Pitt Alumni Association and the Dietrich School. The Deliberative Dialogue series is hosted by the Pitt Alumni Association to promote constructive conversations around difficult topics. The Dietrich School's Science Revealed series aims to highlight the advances as well as the limitations of science, with an emphasis on aspects that are directly relevant to our lives and communities. As part of both of these series, today's event will explore some societal and scientific aspects of health inequities through conversation while encouraging questions from you. Please use the Q&A feature at the bottom of your screen to submit questions throughout the presentations. We'll do our best to answer as many of these questions as possible. And now, I'm happy to turn things over to our moderator, Mario Browne.
Thank you so much, John. And hello, everybody. Welcome. Thank you for joining us for this great dialogue today that we are in store for. As John said, I am Mario Browne. I am the inaugural Associate Dean for Equity, Engagement, and Justice in the Pitt School of Pharmacy. Prior to that, I was the Director of the Office of Health Sciences, Diversity, Equity, and Inclusion in the Schools of the Health Sciences. But I'm here to just sort of guide the conversation, but really introduce our two presenters. The first is Dr. Abimbola Fapohunda, who is in the Department of Africana Studies. Second, we have Dr. Anna Marsland, who is a professor in the Biological and Health Psychology program in the Department of Psychology. And as you can read their bios there on the screen, there's no need for me to read those, but they can tell you more about themselves throughout their presentation or as they choose. So with that being said, I want to turn it over to Dr. Fapohunda. And Abby, the floor is yours.
Thank you. Glad to be here. I'm going to share my screen now. Can you see this?
Yes, we can, Abby.
Okay. Yeah, I'd like to start my presentation by telling you what brought me to this point. I've always been interested in racial ethnicity and disparity among African Americans in the US, and this has led me to my international research effort. And I do believe that there's connections between global and local health issues when we really look deeply into what's going on locally within our own communities and what's happening in other parts of the world. So I started this journey of working abroad through a personal journey. In 2016, my mother was diagnosed with colorectal cancer, an advanced stage cancer. So I had to look for an appropriate place to take care of her for palliative care. And that's how I got to know about this health center in Lagos, Nigeria. I'd like to give you some information about, the population in Nigeria. Nigeria has approximately about 200 million people, and Lagos, where the cancer center is located, has about 22 million. Lagos is one of the most populous cities in sub-Saharan Africa. The issue in Lagos, a problem regarding diseases, cancer, Nigeria has one of the highest rates of cancer in sub-Saharan Africa. For breast cancer, it's 49.0 per 100,000, and for cervical cancer, it's 18.4. So in 2018, I collaborated with Lakeshore Cancer Center. This center is the first private operational health center dedicated to cancer prevention, diagnosis, treatment, and education. And we conducted a descriptive study of cancer presentation pattern in Lagos, Nigeria, using the hospital-based registry. The findings at that time, we found that 49% of patients that presented to the clinic were 50 years old or younger. And most of the cancer type for women was breast cancer. And it was about 46% of people that presented at the hospital, breast cancer was the most common. We found that 92% of cancer patients, the tumor were already malignant by the time they got, they presented themselves. And 97% of patients were symptomatic. So we can see that most patients present themselves at advanced stages 3 and 4. So with that, we decided that, we decided that the step to take is to maybe educate healthcare practitioners. We know there was a gap. Research shows that there was a gap in knowledge of cancer care. And I developed a curriculum and went to Nigeria 2019, February, and did 4 training, training for healthcare practitioners. And then we're supposed to go back last year to do more training, because we initially did 4 trainings, and then we're supposed to do 30 more trainings last year and this year. And due to COVID, it has to be canceled. So then we decided to leverage e-learning tools to start this training and to improve cancer, cervical cancer and breast cancer screening in Nigeria. So we believe that this training using e-learning tools will be able to scale up the skills of doctors and nurses, so we'll be able to improve cancer diagnosis and referrals. So we can see that there's a connection, as I said earlier on, between local and global, and this should not be overlooked. Because as more people from African countries where cancer awareness is really limited due to the lack of education and very weak infrastructure and on like that, people that migrate to the United States, we are assuming that a lot of healthcare practitioners will face the possibility of caring for some of these immigrants. And some of them may already even have advanced stage cancer by the time they migrate into the United States. So that's an issue that needs to be really, that one has to take serious. Now coming back to Allegheny County, because I've already started some research among African immigrants earlier, and this group is really growing rapidly. Even though it seems small, but the number is growing daily, and an estimated number of 5,000 to 7,000 immigrants reside in Allegheny County, and very little is known about them. So we did a study, the study to gain insight about the cultural beliefs and practice and traditions of African immigrants, and to see barriers and facilitators to access to care. And we did a focus group interview, and we were able to conduct it among 30 immigrants. And the results showed us that there's a lot of challenges that exist for some of these immigrants, because navigating the American health systems and understanding what to do on how to really utilize the system. We also found out that secrecy and stigma exist among the beliefs in chronic diseases, diabetes, mental health. people don't want to talk about it. It's not something they're used to. So even if they have it, they're not comfortable sharing it or even going to see the doctor. And self-treatment was very common among this group. And then we saw that religion and spirituality, they use that a lot for common illness. And when they're sick, they believe that, that will really help them. So because of, through this research and the findings, I believe that there should be further research needed, because now we come back to the present, looking at COVID. And we know that some of these beliefs, because talking to the group and being part of the group, we know that fear and this self home remedies and self treatments and religious and spirituality really has an impact on what's going on regarding COVID as well. So a question is, are Black immigrants at more risk? When you look at the statistics, recent statistics, you look at the essential worker, the health workers, the people in food production and biochemical, you can see the percentage, even though they're only 1.3% of the United States population, you have nearly double or more than double in all of these work. So that makes them more vulnerable. So now we are talking about COVID, and we have this vulnerable group of people that have to go out all the time to do work. So then I was a bit concerned about some of the data we've collected about this population, about mistrust of the health system, and I realized that some of them do have the vaccine hesitancy, not believing and getting some misinformation. So I collaborated with the East Liberty Family Health Center, and they were kind enough to really give me access to really bring some of these community members, making sure that they do get their vaccination. And it's been really successful. We've been able to vaccinate a significant number of this population. And because they are really hard to reach population, we were able to reach them through social media, churches, community leaders and organizations, just to make sure that they have that access to testing and vaccination, because a lot of them were really, they couldn't just navigate the system, and it was difficult for them. So the takeaway is that we want us to really pay attention to this group as well, because they are part of the Black population in the United States. And if we are talking about health equity and health, and really addressing the issue of health disparity, this group needs to be part of the story. And we have to make intentional and become more systematic in how we address health disparity. We need to really focus on where these people are and make sure that resources are there for them to be able to access care. So, for example, I'm using the East Liberty Health Center as an example. They have incorporated a whole person care of health and person mind into their clinical care for patients, and they have really incorporated social determinants of health. So it's not just taking care of patients. They are thinking about where do they live, do they have problems with employment, are they able to pay their bills, what's going on with them. So many things that are, so many indicators about social determinants of health. So these are important things, and that's how we are going to truly address the issue of health disparity among people, among disadvantaged people. And that's the overview of my both of my presentations, and then we'll talk about questions later on. Thank you.
Excellent. Thank you so much, Dr. Fapohunda. Really just framing some of the similarities between your research with the African immigrants from Nigeria and the African-American population of women here in America, and then really looking at the commonalities in terms of the determinants of health. And the stress that's involved with navigating the healthcare system in order to both stay healthy, but also to access health, and the intersection of that with traditions and beliefs, very powerful. And it's really a great transition to Dr. Marslin's talk, who will present next. Dr. Marslin, floor is yours.
Thank you. I'm struggling to find my presentation on my screen. Oh, wait a second. Found it. I'm sorry, guys. Is that visible?
Yes, it is.
Excellent. Good afternoon, everyone. My name is Anna Marsland, and I'm a professor in the psychology department at Pitt. My area of research is health psychology. And so I'm very interested in how psychological, social, behavioral factors relate to physical disease. And I have a particular interest in stress, which ties our presentations together. I'm going to talk a little bit today about some research that I've been involved with that looks at factors that make some individuals at greater risk for a respiratory illness than others, that I think is very relevant to our current COVID pandemic and maybe of interest to people. And this work builds on the work of Dr. Sheldon Cohen, who is a professor of psychology at Carnegie Mellon University. And for the past 35 years, Sheldon has been studying factors that predict risk for viral infection. And he's been focused on a range of different viruses, including common cold viruses and flu viruses. But I think his findings are very relevant to the COVID pandemic. So, and my own work builds on some of his findings. So I wanted to start by telling you a little bit about his project, his findings, and his work, and then talk about how that's informed the research that I do. So Sheldon, for many years, has been using an experimental model called a viral challenge model. And this is a study design where healthy volunteers agreed to take part in the research, and they come in, and the very first thing that he does is characterize them and really understand them as people. He asks them to complete questionnaires about their socioeconomic status, about their levels of life stress, about their social relationships, about their personality, and many other things. And also asks them to complete measures of their lifestyle behaviors, like their sleep, their eating, their exercise habits. After he's characterized the individuals, he exposes them to a virus. And you can see in this picture here, someone being exposed to a virus. It's literally the virus is squirted up a nostril. And then the individual is quarantined for 5 to 6 days to see, firstly, if they develop an infection, and that's measured by looking at antibody levels to the specific virus, but also to see if they develop symptoms, and if they do develop symptoms, how severe those symptoms are. And that's assessed by asking people, but it's also assessed by objective measures. So they do things like measure the amount of mucus being produced as an objective measure of the symptoms. So over 35 years of studies in doing this challenge, he has recently written a review paper drawing findings together. And what do we know? We know that 70 to 80% of those who are exposed to the virus become infected. So that's interesting. Even with direct exposure up a nostril, there are a number of people who don't get infected. And also interesting and relevant to the current pandemic, 25 to 40% of those infected develop symptoms. And that's similar to what we're hearing about COVID-19, where everyone doesn't develop symptoms. So the question then becomes, who are the people who are at risk of developing respiratory illness? And how are they different? Are they different in any systematic way from those people who are more protected? And he has spent a lot of his life's work examining this question. And he recently published a review of studies that drew together consistent findings, and across many hundreds of people who've taken part in these trials. He concluded that the individuals who were at increased risk for respiratory illness were individuals who, from a behavioral perspective, were more likely to be smokers. They exercised typically less than 2 days per week. They had poor sleep and got less than 6 to 7 hours of sleep per night and didn't sleep well. And they had a diet that was low in vitamin C. Of particular interest to me was the fact that they were also at psychological and social risk. Individuals who were more likely to develop illness were individuals who reported chronic psychological stress, economic stress, unemployment, stressful life events, higher perceptions of stress, negative emotions like depression and anxiety, and reported that they had fewer social relationships and less social support. So from a psychosocial perspective, these individuals were vulnerable to physical illness. We don't at this point know whether this extends to COVID-19. Those studies are currently underway, but there's a lot of reason to think that it might, given that this is seen in Sheldon Cohen's work across a range of different viruses. So my own work has asked questions about how could this be? How could stress, things like economic challenges and discrimination, have an impact on who gets sick and who doesn't get sick? And this is my work, which is really focused on the association between stress and the immune system as one pathway by which these factors might get under the skin to influence rates of infection and illness. So I'm going to spend just a moment talking about inflammation because I think it's a really interesting topic and very relevant. So this little cartoon thing over here shows us what happens when, this is actually showing the surface of the skin. This is a wound, but imagine this is the lining of the respiratory tract. And here these little black cylinders are a virus that's gaining entry into the body right here. In the tissue, we have immune cells that are resident, and there's a particular immune cell here called a macrophage. And what happens is this macrophage usually doesn't do much of anything, but when it actually recognizes a virus, it becomes activated. And as it becomes activated, it produces these chemical messengers called cytokines. These cytokines contribute to the local inflammatory response. So the inflammatory response you're familiar with, if you injure yourself, you get an area very quickly around that injury of redness, swelling, pain. That's an local inflammatory response. Cytokines act on blood vessels to cause the cells that line the blood vessels to separate. So fluid leaves the circulatory system, the bloodstream, and pools in the area of the infection. Cells travel to the area of the infection. These cells are really responsible for destroying and removing the virus. The fluid that gathers here causes swelling, presses on free nerve endings, causes pain. We have other cells that release things like histamines, and these histamines play a role in increasing mucus production. So what you have here is a local inflammatory response, but if this is in the lining of the respiratory tract, this causes mucus production, irritation, which causes coughing and sore throat, and are the symptoms that we experience of respiratory illness. Now, these cytokines do more than just coordinate this local inflammatory response because they actually enter the bloodstream and travel to the brain. And in the brain, they play a really important role in what we call symptoms of sickness. So when you've got the flu or a really nasty cold, you feel really unwell, you lose your appetite, you find it difficult to concentrate on things, your mood is low, these we call sickness symptoms. Oh, and I forgot fever as well. All of those symptoms are actually stimulated by the level of cytokines in the circulatory system that travel to the brain, communicating that there's an infection going on, you're fighting an infection, and actually causing the person to cancel work, go to bed, and save their energy for fighting the infection. So these are thought to be adaptive and associated with improved chances of survival. So this is the inflammatory response. The key thing about the inflammatory response is we want it to be large enough to be able to handle the infection, but we don't want it to be too excessive, because if it gets too excessive, then the mucus production, the inflammatory response itself can actually become toxic and cause damage. And we see this in COVID, when you actually get a lot of mucus and inflammatory responses, preventing oxygen exchange and decreasing in severe illness, decreasing the ability of people to breathe. And ultimately, that response, that so-called cytokine storm, is a piece of what can make the infection life-threatening. So what's really interesting to us in the field is that chronic stress that we talked about, that is associated with increased respiratory illness, actually drives the overproduction of inflammatory cytokines. So increases the magnitude of this inflammatory response. So these are results from one of the cold trials. This trial was influenza A that people were exposed to. So it's a flu virus. And here, what you see in the black lines here are individuals who are high in perception of stress. The broken lines are people who are lower in perceptions of stress. These are the days of quarantine. This is the day of infection right here. Here we have the total symptoms. And so you can see individuals who are higher in stress are showing a greater increase in symptoms. This is the objective measure of clinical illness. This is mucus weight. And here you see the individuals high in stress have greater mucus production. And this is IL-6, which is one of those inflammatory chemical messengers, the cytokines I talked about. And you can see individuals high in stress produce more of those cytokines. And what's interesting is the magnitude of this increase in cytokines relates to the stress-related increase in symptoms and mucus weight. So this is a pathway, this stress-related increase in inflammation is a pathway that links the experience of stress with worse clinical illness, greater mucus production. And we think that this pathway is very relevant in the context of a risk for severe illness in response to COVID-19 virus, and may contribute to some of the statistics we're seeing in regard to risk for that illness and risk particularly for severe disease. I threw this slide in here because I think it's interesting and relevant for our discussion. And this just talks a little bit about the fact that discrimination is a chronic stressor that is experienced and contributes to this inflammatory response. So when compared with white Americans, Black Americans actually show, on average, greater activity of pro-inflammatory genes. And interestingly, the experience of racial discrimination accounts for about 50% of this increase. So this is a pathway whereby discrimination can actually contribute to worse viral infection. So there's lots of implications for COVID-19 here from this work. We know that the pandemic has caused increases in levels of chronic stress, anxiety, and depression. That has been recorded. Very interesting new data that's being published right now from the UK shows that the magnitude of the stress and of distress in response to the pandemic actually predicts risk for COVID-19 infection and the number and severity of COVID-19 symptoms. So it seems to me like this virus is tracking in exactly the same way as the viruses that Dr. Cohen has explored in the cold studies. We know that higher levels of cytokines predict disease severity, and in severely ill hospitalized patients, some of the treatments actually focus on blocking those cytokines and using anti-inflammatories. And so it's really possible that chronic stress could play a role in the onset and progression of COVID-19 through its impact on inflammation and increasing this inflammatory response. I have a couple more slides. I know I'm out of time, but I've also done research which is relevant to the pandemic in regard to whether psychological factors influence vaccine response. We don't know yet whether these psychological factors influence COVID vaccination response. The research is being done, but what we do know is that for a variety of other vaccines, including flu, hepatitis B, typhoid, and pneumonia, psychological, social risk factors like chronic stress and those risky health behaviors actually impact magnitude of response to vaccination. Here's some results from my lab here that I think are interesting. These are results, antibody responses to hepatitis B vaccine. This shows the number of hours that people sleep, and this is antibody response. So here, individuals who sleep more than 7 hours per night are showing higher antibody responses to hepatitis B vaccine than individuals who sleep less than 6 hours. And interestingly, these two groups, the less than 6 hours and more than 7 hours, are clinically different. The longer sleepers are clinically more protected from hepatitis B disease. Good news to end on, there's some positive findings too in this literature. Some of the findings show that individuals who are more positive in their emotional style actually have a decreased risk. These are the individuals with the white in the white here are more positive. This is the cold study data showing that they have a decreased risk of clinical colds. And here, this is some of my own results on vaccination response, showing that individuals who mount higher antibody responses to hepatitis B vaccination are individuals who describe themselves as more positive and higher in positive emotions and lower in negative emotions. So it certainly pays to be happy. And then I think that there are many, many ways that we can think and talk about of trying to manage stress on an individual level, you know, things like exercising regularly, mindfulness meditation, spending time with friends, getting enough sleep, eating, seeking professional help when needed to manage symptoms of depression and anxiety. But I think on a societal level, we have some bigger challenges that warrant discussion in regard to levels of stress and disparities that contribute to risk for disease and are relevant to some of the findings that Abby presented in regard to health disparities. So I will finish there. Thank you.
Excellent, Dr. Marslin. Thank you so much for that. And definitely a great opportunity now for some dialogue, both between our panelists and from our audience in terms of the connections between Dr. Fapohunda's presentation and Dr. Marsland's. I want to, before I open up Q&A to everyone, I just really want to emphasize sort of the connection between behavior, between beliefs, because what really popped out to me in terms of both of you all's presentations were individual and community health belief models in terms of what they can, what they will accept and won't accept when it comes to health and disease, and what they will and won't accept when it comes to wellness, prevention, and actually health-seeking behaviors. So I just want to ask Abby, in terms of what Anna just presented there, because I remember our pre-conversation, and there definitely was a lot of dialogue. So I want to just really open it up to both of you first in terms of some commentary back to your colleague. in terms of what was presented so far, or what the two of you presented.
Thank you, Mario. And thank you, Dr. Marsland. It's really interesting listening to your presentation because it just brings a lot of thought in my mind that what we are talking about regarding social determinants of health really is connected to what you're saying, because with all social determinants of health, which really determines if you're going to be healthy or not healthy. And when you're talking about someone having a very low immunity and you are not sleeping well, you're not eating well, and you don't have access to certain things, and maybe you don't have a job or so, all of that is really connected to the person's body. And at the end of the day, you tend to be more vulnerable, catching infectious diseases and even chronic diseases. And no wonder when we are talking about people of color and thinking about, why are they sicker people? Why do they die more or prematurely die? You can see where it comes from, because the body is vulnerable. So you tend to pick up, infections. You tend to pick up, you end up having chronic diseases, and that's the way it really connects to Dr. Marsland's work is very interesting, because it's all about the social determinants of health, and healthy environments produce healthy people. And most of what we talk about, if you don't have resources to all of these and access to all of these, you create an environment that is not conducive to good health.
Can I jump in, Mario?
Oh, absolutely.
Abby, I so agree with everything you said. I also was very taken by your presentation, because I think that the immigrants that you are working with handle challenges on multiple levels that impact them in many ways, but impact their biology as well as all of the other challenges they face. Just challenges of life, challenges of work, challenges of finances and employment. And I think just the stress of, I don't know how to say this, but of living in this community and in this social structure, I think it could be very overwhelming, and it would be very easy for me to imagine they would be a particularly vulnerable group in regard to health disparities and health risks as a consequence of those exposures.
And can I come in? Thank you.
Yes, please do.
Can I come in a bit? Because that's why you see research. We have evidence that when immigrants get into this country, most of them, in good health, but with time, by the time they get to that mark of 5 years to 10 years, they begin to develop chronic diseases. They begin to pick up, a lot of chronic diseases, and they get sicker. So the longer they stay in the United States, the health tends to really deteriorate. And you can see, as you said, that stress, chronic stress does a lot to the body. And this group of people, that's why we need to pay attention to them, because they're like a group within a group. So a lot of people don't even really do examine lots of things or study about this group. And this group of people, they're not dealing with just stress being in the United States. They're dealing with stress back home as well, because many of them still have families back home, extended families back home that they take care of. And then when you're dealing with stress here and thinking about families back home, it's a double whammy on their health. And that's what happened during COVID. They're thinking about their families back home regarding COVID, for them, hope they survive and all that, and then thinking about themselves here as well. And some of them still have to go to work. Even in the middle of COVID, they still have to go to work to earn money. So that's why it does a lot to the body.
Yes. So both of your comments, thank you for that. really lends itself to a two-part question coming from our participants. And one is, when we speak of stress, and Abby, you just touched on it, when we speak of stress as a risk factor for illness, how important is chronic ongoing stress versus acute shorter term stress? And a follow-up to that is, what is known about the impact of stress factors on cancer rates and cancer severity? And that's for either one. That's for both of you all.
Yeah,
acute chronic stress one.
Yes, and why don't you take the stress app, and Abby could take the.
Okay, so I do research on both chronic stress and acute stress, and the short answer is it's really it's hard for us to really know, but it's likely that both play a role. In regard to health outcomes, I think chronic unrelenting stress is particularly detrimental. But chronic stress actually involves multiple experiences of acute stress. You know, individuals who are, the individuals Abby's talking about, who are dealing with challenges of being an immigrant, having family back home that they must be worried sick about, and then also just the challenges of life in a very different culture. There is a chronic stress piece to that, but then there are challenges that on a daily basis they probably confront in getting their needs met, in juggling work and home, and making decisions. So it's very hard to, in regard to sort of long-term studies, to actually pull apart acute and chronic stress. I will say that there is some evidence to suggest that biologically speaking, individuals vary in the magnitude of their responses to acute stress. So there might be some individuals who are just by disposition more vulnerable to show biological responses to acute stress. So that, I think it's complicated and there are many factors, and it's a great question.
Yeah, I do support what you said, you know. Talking about immigrants, because I just say there's this connection between local and global. When you're talking of people that migrate into this space, they have already, you know, most of them have already experienced chronic stress from where they're coming from. So it's not unusual that some of them are already developed illnesses which hasn't really been diagnosed, you know, until they get here. And, you know, when you talk about cancer, thinking of someone that who hasn't even migrated, and just being in a space where healthcare is very, very limited, and the health infrastructure is very, you know, it's not the best. And then you end up having been diagnosed with cancer. It just, you know, it's a very, very stressful experience for the family, because the first thing they think about is, can I even afford to go to the hospital? And that's why we see, you saw in the result I presented that nearly everyone that at that clinic already have symptoms, and they are the late stage of the disease. Is because they delay treatment, because they think of how can we afford to treat this? And with those kinds of stress, you can see, and the mindset and the perception they have from their native country, they bring it into this space as well. So even if they have that access to care as well, they still have a perception of healthcare, and they may still not, you know, come for care early enough, except when you start educating them.
Yes. Dr. Marslin, when you were speaking, it definitely made me think about the sort of the science, more of the science, right, behind stress, and that whole idea of homeostasis, right, where we all have acute stressors, and then we are supposed to come back down to some level of normalcy. But as Dr. Fapohunda talks about, right, for many populations, and even what you said in your presentation, there are whole populations that never come back down to homeostasis. So then you have this precipitating another insult or precipitating event such as COVID, and having to already navigate chronic stressors, but now you have to navigate through this acute issue, such as the pandemic of COVID or cancer, right, Abby? Where now, how do I even seek out proper treatment? How do I afford it? What are all of these studies that people are talking about? So much to think about there. That really lends itself to the whole idea of this deliberative dialogue. So let me get to a few questions, because the questions are piling up for you guys. How long will it take until we know the effect of psychological factors on vaccine effectiveness? How long will it take until we know the effect of psychological factors on vaccine effectiveness?
Well, that's for me, I'm sure. So I think there's a group in the UK who are the furthest along with answering this question, and they have a very, very large trial going on at the moment where they have characterized individuals, and they are looking at a range of different ways of looking at the efficacy of the vaccine. How long will it take? My guess is that they will. Well, they're underway, they've recruited, the people are in the study, and they are following them out now. So my guess is preliminary results will be coming out, probably within 6 months. They are a very active research group. So I think we'll know no more than we know now in 6 months' time. That's my guess. It's a guess.
Very good. And so I want to pose this question to you, Abby, and I'll combine this. Do you have any systemic or community-focused initiatives to propose with respect to uplifting vulnerable communities that communities can work towards? And I'll dovetail another question with that. Specific minority groups were discussed in both of your talks. How do you advise someone to work effectively with these populations collectively?
Yeah, there's some groups here in Pittsburgh, some community-based organizations that are working with minority population. The Allegheny Health Network, they have different, committees and different organizations working with minority populations. And we have, for example, I used the East Liberty Health Center as an example. I'm really fascinated about the work they've been doing, because I'm one of the board of directors for that clinic. What they've done is they've really incorporated social determinants of health into their care. And I think that's the best approach, because if we truly want to address this issue of health disparity, we need to be deliberate about it. We need to really have a plan and make sure that this plan is going to really work. But sometimes we talk about it, we present things about it, but there's no real plan that will work and which is sustainable. So an health clinic, an health center within a community, a disadvantaged community, and then incorporating social determinants of health into their care. I think that's the best approach, because most people, the reason why they end up at a clinic or hospital may not just be, okay, they have hypertension, they have diabetes, but if you look deeper into their lives, if you go back home and look at their life, it may start with losing a job. It may start with losing a child to gun violence. It may start with the neighborhood. It's a very, very, they're just victims of daily gunshot and all of those that causes this chronic stress. So at the end of the day, all of this compounds and they end up with high blood pressure. And if it's not managed, then they end up with diabetes. They can't walk in their own communities. There's no place to go and have a nice walk in the evening. And you as a practitioner, you're giving them all of these treatment plans. It doesn't work where they come from. All of this doesn't work. So at the end of the day, if you're able to deal with some of these social and economic factors and be able to address it where they live, where they work, where they school and all that, you will see less people come to the hospitals. There'll be less hospitalization, and because they'll be able to manage afford their medication. And that's why they don't use it and they get sicker and then end up in a bad space. So, and you find out that healthcare is just about 30%, 20 to 30% of, being healthy. What makes people healthy? 80% of what makes you healthy are the other social determinants of health, dealing with it. So I feel a place like the health center, that approach, when you come in, they start with a questionnaire that examines about 15 factors. They look into housing, employment, utility assistance, food security, safety concern. And when they find any gaps, they're able to now send it, refer their patients and then deal with the clinical stuff. And I think it's a very good approach to really deal with this issue of health disparity.
Absolutely. Meeting people where they're at is what I just heard you really say, assessing where they're at. And so we're running short on time. We have about 7 minutes left, and there are a few more questions. So, and I want to come back to you with this one, because one of the things that some colleagues have told me throughout the years in terms of addressing health disparities sort of on the individual or communal level is this idea of mindful meditation. And I never really got what they were talking about, but listening to what you just presented on how it affects the inflammatory system, it is a tool that anyone can use. And when it comes to social determinants, it's not one where people are priced out of being able to use this intervention. Can you describe mindful meditation for us in a thumbnail?
Yes. So it is a remarkable way of helping to manage emotions, where people are trained to accept emotions as they are in a non-judgmental way, and to be able to be present in the moments they're in. People spend a lot of time living in the past or worrying about the future, and mindfulness really helps people to learn techniques and to be able to be present in that moment in time, and to handle whatever you have to handle in that moment in time without layering on top of it other stressors, other things that are surely there, but in that moment, they don't need to take your attention and take away from what you have to deal with. So I don't know if that's, there are many techniques that full mindfulness interventions involves yoga, it involves meditation and many different ways, and it takes some training and practice. But people who really stick with it and practice find it enormously helpful in confronting challenges, many challenges of life. And it would be wonderful to get something like that training into the health centers, Abby, that you're talking about, because one of the challenges is getting these interventions to the people who would benefit from them in a way that they can actually make use of them. And we're trying right now. In fact, there's a junior faculty member in psychology, Emily Lindsay, who's been working on creating mindfulness apps so that people can actually work on practicing these things in their home, in the safety of their home environment. But it's a skill set. It needs to be learned, but I do think it's one piece of what I see as a very complicated puzzle with multiple layers that need to be in place, including societal interventions, in order to really make a difference with health disparities.
Yes, thank you for that. And you're absolutely right. One layer, because we're not even really talking about policy, are we? Which really is where we can get bang for our bucks. Couple more questions. So I'm going to ask you all to try to hit these in a 2 or 3 minute stance. Abby, Terrence wants to know, he was really looking at in Asian American communities, asking about Asian American communities and the perception of health seeking can affect their conceptions, or if they can qualify for citizenship. So this whole idea, now we're bringing in the political, right? Where when we're talking about immigrant populations and how they will sacrifice their health out of fear of being not accepted into into our society. Can you speak to that at all in terms of that challenge?
Yeah, what I know, and with my personal experience and experience of people around me, the fact that you are in this space could be very, very challenging, because it's, wherever you come from, moving into a new space, because many immigrants left loved ones behind. So the fact that you've left loved one behind, that, kind of isolation by itself, dealing with that and really getting used to your new space and surviving and thriving, sometimes it takes longer for some people than the other. And then they now to navigate the system. And then you brought with all your life experience and perception into this space. And so for some people, they can let go, easily, whereas others, it's so difficult, it takes so long. And all of these factors usually have an impact on their day-to-day decisions. I hope I answered the question, because I don't want to go too long. So
yeah, absolutely. No, and we could definitely drill down there, but what you just said was in terms of making decisions, life decisions about their life as it relates to their immigrant status, is something that we as health professionals need to be mindful of and need to be aware of. Absolutely.
Yeah.
And so Anna, actually, what I will do is in 1 minute's time, if there is one closing statement that Anna, you want to leave people with, and you as well, Abby, before we depart from here.
I would just say we're beginning to understand these pathways that contribute to health disparities, but the challenges remain in how to address them and are complex, but really need attention.
Excellent.
Yeah. I would say, like the work, for example, that Anna does with other colleagues, we need to really, share that even among communities, and then continue to deliberately really work towards addressing this issue of health disparity. We just don't want to deal with it by one factor at a time. It's something that we have to deal with the whole issue at once, and which is very, very challenging to do. And that's why we still, this still persists. But
wonderful.
We have to continue the work.
I want to thank you both for a very insightful and great presentation and discussion today. I want to thank everyone for tuning in. Please follow the Dietrich School and Pitt Alumni Association, where you can view on YouTube, and you can view more deliberative dialogue and science reveal sessions. Thank you so much, everybody. Have a great day.
Thank you. Bye-bye.